ASD.
An ASD is a hole between the two collecting chambers of the heart, which are called atria. There's a left atrium, which collects blood from the lungs, and there's a right atrium, which collects blood from the body. Blood should not mix between those two chambers, but occasionally there will be a hole between those two chambers in different locations along that atrial septum, the wall between the two atria, and that's called an atrial septal defect.
Do these have to be corrected?
Very small atrial septal defects might not need correction, but the majority of them do require correction at some point.
Is there a way of doing it with a catheter as opposed to a major surgical procedure?
For one of the types of atrial septal defects, in fact the most common type, a secundum type atrial septal defect, which exists right smack in the middle of the atrial septum, the majority of closures these days are done with catheter-based devices, which are basically umbrella-type or mushroom-shaped plugs that are put from within the bloodstream into the hole, and they open up and they pop open and occlude the hole.
If you do put that kind of device in, and it's obviously not part of your body, the person has to go on anticoagulants for a certain period of time?
Generally, the patients are placed on some sort of antiplatelet medication, whether it's aspirin or Plavix, for a short period of time, but long-term therapy is not needed.
The reason for that is some kind of a membranous material overgrows the area?
The devices are designed such that the body covers them with its own lining of tissue, and the devices become, in fact, relatively invisible to the body in a short period of time.
What would be the ones that you would eventually have to do surgery on? What would be the criteria?
Well, there's two situations that we do surgery for atrial septal defects. For secundum type atrial septal defects, we would operate on patients for whom devices are not appropriate. And those are patients in whom the ASD is extremely large and the device either might not exist in a large enough size or would be so large that it would risk injuring the heart in some way or poking outside the heart or poking into one of the other cardiac structures. Sometimes also the secundum atrial septal defects will not have an adequate rim, is the term that we use, but it will not have an adequate amount of tissue around it for the device to anchor. The device needs a certain amount of tissue to hold itself onto. So if the device is not technically possible or is felt to be of significant risk to the patient, then surgery is a better option. In addition, there are other types of atrial septal defects, including a primum type, which is located down near the valves that separate the atria from the ventricles. And also there's a sinus venosus type, which is located very high in the atrial septum and generally involves some abnormalities of the veins that bring back blood from the lungs. In those two cases, device closure is not appropriate and surgical closure is still required.
How complicated is the surgery?
Surgery for atrial septal defects of any kind is quite straightforward and is done with less than 1% risk to the patient of any significant long-term sequela, and generally with quite short hospitalization.
Do they have to go on a heart-lung machine?
The patients do have to go on a heart-lung machine for us to close these atrial septal defects, but particularly for young patients without any significant comorbid diseases, in other words, without any significant other medical problems, the risk of the heart-lung machine in modern times is extremely low. And in fact, the use of the heart-lung machine makes any operations on the heart much safer to the patient.